Hi, everybody. I think we're live. So it's lovely to meet everyone. My name is David Putrino. I am a professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai, which is a big medical school and hospital system in New York City. I'm also very proudly a member of the Board of Trustees for the SameYou Foundation and charity across the US and the UK. And today is an AMA event where you can ask me anything about brain injury and brain injury recovery. And I think that this is something that we're going to really just continue to do over the next few months to years so that we can create a link between the public and all sorts of professionals who work and research brain injury so that we can answer questions that are out there. So I believe that Maddie, who is a wonderful person who also works with SameYou, has some questions in hand, and she's going to start feeding me some of the questions from the public so that we can start to talk about them and discuss them.
Absolutely. And so our first question is, can you tell us a little bit more about the collaboration with SameYou?
Sure. So, one of the things that we think about a lot at Mount Sinai is how can we also always be offering more and better services to people who are recovering from brain injury. And as a result, we have started to collaborate with SameYou because one of the things that most of our patients tell us is everything in the hospital was great. We had good services, et cetera. And then when I left the hospital, and whether that be a Mount Sinai hospital or any hospital around the world, the sort of feedback is the same. It feels like I dropped off of a cliff. I feel like I struggled to find services. I feel like I, didn't know anyone in my neighborhood who was also going through the things that I was going through. And so, one of the big missions of SameYou is to create community in people with acquired brain injury and help folks with brain injury to, to be able to access these sorts of services. So we are, really starting to think about how we can partner with SameYou to create peer support programs and to really expand the services that we can offer people once they leave the hospital so that they get a really uninterrupted continuum of care through their lifespan.
Thank you for that first question. The next question that we have is, what is one thing that you wish every patient or caregiver understood earlier about the recovery process?
I wish that one thing that I wish that everybody understood, from clinical providers all the way through to patients and their family members after a brain injury, is that brain recovery from a brain injury is lifelong, meaning that there's all of this, sort of dogma and bad information out in the world that once you sort of get to 6 or 7 months after your brain injury, we're often told, well, that's all the recovery that you can expect. We're told that recovery rates start to plateau and people don't recover so much after that. Consistently in the literature, we have shown that that is not the case. We have shown that people really do experience lifelong recovery. Now, the treatment strategies may change. The rehabilitation strategies may change. We may need to use new or different technology or approaches to make sure that you continue to get gains. But the point is that continued gains are possible. And so from a clinical perspective, clinical providers should never be telling a person, you're done with recovery, that's all the recovery you're ever going to do. And from a patient and caregiver perspective, what I hope that we can do is be a bridge that links them to services that allow them to continue their recovery journey as far as they want to take it. The only time that we want to stop offering options to people is when the people that we are serving are saying, okay, I'm actually happy where I am, and I don't need to be putting any more time into rehabilitation or care. So the one message that I hope people take out is that brain injury recovery is lifelong, and we can always be doing more to optimize and improve on what we've got.
I think that was a fantastic introduction to our next question. The next question that we are asked is, can you talk a bit about persistent symptoms after concussion, especially related to post-exertional malaise or post-exercise fatigue?
Yeah, absolutely. We frequently see people who, there's a subset of folks who do not immediately bounce back from a concussion. In the majority of times after people sustain a concussion, it is true that spontaneous recovery occurs, and people will typically return to baseline, within a week or two after a concussion. However, that's not the case for many people who experience a concussion. Often symptoms can persist for a long time. And one of the hallmarks of concussion, post-concussion syndrome, which is what it is called when someone fails to return to baseline after a concussion, is post-exertional symptoms. So people who experience either exacerbation of their concussion symptoms or onset of new symptoms after they exert themselves. I think it's really important to note and be aware that that these post-exertional symptoms, exertion can take the form of physical exertion, so getting up and trying to go for a run and sort of get yourself back into your previous fitness routine. It can take the form of cognitive exertion. So actually you're returning to play, you're returning to your previous fitness routine just fine. But when you sit down in front of a computer and try to do your day job, like work on a spreadsheet or study or read something on a screen, that is the form of exertion that causes these symptoms to emerge. Or it can actually take the form of emotional exertion. So many people will report to us that they had a stressful conversation, which sort of raised their cortisol levels, which is this stress hormone that floods through our body and is actually pro-inflammatory. Or they had to do something that took a lot of emotional labor, and afterwards they crashed as a result of that, when ordinarily they would be able to handle that in their day-to-day just fine. And when it comes to identifying these post-exertional symptoms, the first thing that's very important for a provider to do is to identify them, identify that they're happening, provide reassurance and understanding to a person recovering from a concussion that these are normal and these are things that people with post-concussion syndrome will experience, and then coming up with strategies that can allow us to manage the post-exertional symptoms. One well-known strategy for post-exertional symptoms is an energy conservation strategy known as pacing, which allows people to very carefully understand the sort of ranges of activity levels that they can perform without triggering symptom exacerbation, slowly and steadily over time, while their body has that opportunity to recover from the concussion. So they can sort of map out a plan of saying, this is how much I can physically exert myself today before I flip a switch and I move into this exertional symptom environment. And while we're figuring out all of these pacing strategies, then we can start to layer on medication approaches to treatment, rehabilitation approaches to treatment, and really working to help people through this tough time.
Yeah, thank you for that answer. The next question we have kind of touches on something that you just mentioned about kind of visual stimuli affecting survivors of TBI. So the question that we have here is, how can visually stimulating environments like patterns, lighting, optical illusions, or motion, how can they affect recovery? And does this depend on the type or severity of the injury?
That is a great question, and one of the biggest challenges I think about managing concussion and brain injury is that every single patient is unique, and every single person has sustained a slightly different injury from every other person. So there is no one size fits all to brain injury recovery. You really need to sort of take every single person as it comes. And so the question of, is this a hallmark of severe injury? I would say no. We have some people who have extraordinarily mild, brain injury that they've sustained, or a mild concussion, but their visual symptoms are the most prominent. So really, it's a matter of just understanding, why these visual symptoms are emerging, and to that end, to the end of the question about some of these visual stimuli, we always think about environment as it's never neutral. Environment after a brain injury either helps or it harms. It's very rarely neutral. And what I mean by that is, if you are experiencing a brain injury and you are starting to notice that you have visual symptoms, it's important to try to optimize your environment to make sure that you're not triggering those visual symptoms every single day. And so that can mean avoiding bright lights and making sure that you're changing your room to sort of have warm, soft lighting. It might mean avoiding screens or avoiding TV shows that may have some sort of like highly, visual stimulating and flashing environments. But most importantly, what we want to do is get to the bottom of why you're having the visual symptoms in the first place. And that's where working with neuro-ophthalmology or optometry becomes really important, because there are a number of reasons why these visual symptoms may emerge. Where we could probably spend an hour just talking about the visual symptoms of brain injury, but very, very, very briefly. Often visual symptoms can occur because the eye itself experienced a jolt, and therefore some of the visual information that is entering your brain is now altered a little bit, and we need an optometrist to evaluate that and make sure that things are working properly, and if not, how we can correct them. And other times, the sort of circuitry that controls our head movements, our eye movements, and even our sort of balance information that our ears and our inner ears collect gets discombobulated because of the hit to the head. And then in a case like that, once it's been identified that this is the problem, you need to work with visual rehab specialists. These can often be physical therapists or physiotherapists, occupational therapists, or sometimes, again, optometrists or neuro-ophthalmologists, who will help you to recalibrate these three very complicated systems: vestibular, which is our balance in our inner ear, musculoskeletal, which is our ability to move our head around, and then ocular, our ability to move our eyes around. But either way, we need to understand first what's driving the visual symptoms. Then we can come up with a strategy to treat them.
Thank you for that. The next couple questions that we have are kind of focused on life after a previous TBI where scans are normal. So the first question that we have is, what can contribute to persistent symptoms like dizziness or balance problems after something like a subarachnoid hemorrhage or an aneurysm, even when imaging is now normal?
Yeah, this is a great question, and you know, one of the things across the board in the work that we do in the Department of Rehab and Human Performance is we always try to get the message out there that when somebody comes to us with symptoms, if somebody comes to us and says, "Listen, I'm dizzy, I've got headaches, I can't figure it out," and you send it out for testing, and all the testing comes back normal, quote unquote normal. Normal testing should be the beginning of the investigation, not the end of the investigation. So it's the beginning of the investigation because regardless of if the testing is coming back normal, someone is still standing in front of you saying, "I don't feel normal." And so that should trigger us to start to go deeper and try and understand, okay, well, what really is happening here? And a lot of things that can go wrong that frequently do not show up on imaging, routine imaging. I would say probably the top two would be autonomic nervous system dysfunction. And I'm going to sort of break that down. We have a part of our nervous system called the autonomic nervous system, and it controls all of these things in our body that are under what we call autonomous control. So you've probably all heard of autonomous driving cars, these cars that sort of manage to drive around a neighborhood and not need a human driver. Our autonomic nervous system controls things under autonomous control. So things we don't think about, but our body does without us thinking. So digesting food, regulating our blood pressure. So when we go from laying down to standing up, our heart rate and our blood pressure need to accommodate so that we don't lose blood supply to our brain and fall over. Our autonomic nervous system does that. It also does a lot of sensory integration so that we don't need to think, hey, if I'm turning my head to the right, I should also move my eyes to the right. I should also move my eyes to the left if I want to be fixating on something. It figures all of that out for us. It's actually quite ingenious and incredible in its ability to do that without us having to sort of consciously think about it, all of the time. What we know for sure is that brain injury can often disrupt the autonomic nervous system, especially hemorrhagic, especially aneurysm bursts or hemorrhagic strokes that can cause a little bit of brainstem damage. Our autonomic nervous system, the circuitry that controls all of these things, is in our brainstem. And so when someone has had a severe bleed or a bad bleed, often brainstem damage comes alongside that. It doesn't usually show up on imaging or scans so prominently, but what we see are these symptoms, this idea of, oh my gosh, I get really, really dizzy if I go from sitting to standing too quickly. Or if I'm, laying down and I sit up on the edge of the bed, I get extremely dizzy. So autonomic nervous system is one of these things that imaging typically won't show that you're having problems, but it can be a significant source of symptoms. And we can test the autonomic nervous system quite accurately with testing paradigms called a tilt table test, which allows us to evaluate exactly what's going on in your autonomic nervous system as we challenge it. So as we get someone from laying down to tilted up and laying down again, we can sort of measure what's happening to their heart rate and their blood pressure and understand, are we influencing, is the body able to accommodate to these changes, or are you experiencing dizziness, nausea, all of these, common symptoms? Another source of underappreciated, I think, dizziness and sort of symptoms of that nature in people after a brain injury can also be actually involvement of their upper cervical spine. So our spine, especially our C0, C1, which is the sort of joints that connect the head to the neck, as well as our C1, C2, which are the joints that connect the C1 vertebra to the C2 vertebra, exert a lot of control over headaches, dizziness, nausea. We sometimes call this cervicogenic dizziness or cervicogenic headaches, which is just a fancy way of saying headaches and dizziness that have a source that is coming from the neck. And often people who have survived a significant brain bleed, it's not spoken about so much, but they often do experience a little bit of neck trauma, like a whiplash, because often what happens, unfortunately, in the moment of the brain injury is that they fall, so they were upright or they were sitting on a chair or something like that, and the brain injury happens and they fall over. And that causes a little bit of a shock wave to go through their body, and they can experience almost like a whiplash injury. And so that can result in headaches and nausea and dizziness and, all of these symptoms. And because everyone's focused on the brain, hey, you had a brain injury, so I'm going to focus on the brain. No one actually thinks to evaluate what might be happening in the neck. And so that's a part of a routine assessment that we do, especially when people are experiencing these dizziness and nausea symptoms, and the imaging can't seem to explain it. This is often an alternate route of assessment. And then once again, just like a concussion, imaging often won't show the sort of ocular issues and ocular tracking issues that can sometimes be related to headaches and dizziness and nausea. So having a good neuro-ophthalmologist or optometrist perform an assessment is important.
That's very interesting. I think that was such a great explanation to that question. I think on a similar topic, one question we got in the chat was, how do healthcare professionals determine what types of sports, exercise, or physical activities are safe after a recovered TBI? And does having a prior brain injury make you more vulnerable to future head injuries?
Yeah, this is a great question. And return to play after let's call it a concussion. Let's say a mild traumatic brain injury. So when we're thinking about return to play after a brain injury, as a provider, what we're always thinking about is what we call a return to symptom titrated physical activity. And again, that's a sort of a fancy terminology, but what we're really talking about is how far can we push your physiology without triggering symptoms, and how do we keep you just below that symptomatic level so that you're doing actually as much as your body can handle, which is important for the rehabilitation process, without triggering symptoms which can cause sort of relapsing or remitting symptoms that are actually problematic for you and can impede your continued recovery. And I'll also state that no one should we're obviously not going out there to try and trigger symptoms, but we should also all of us acknowledge that recovery from brain injury, especially recovery from concussion, can be a bit of a 2 steps forward, 1 step backward as proposition. I always tell people coming to our center that recovery is never linear, right? Like, it would be nice if I could just say, hey, your function is just going to improve and improve in this very straight line. But actually, what we typically see is you sort of have this like, hey, I'm recovering a little bit, and then boom, I push too hard and I'm back down a little bit. Now I'm recovering a little bit more and I'm back down. And that's typically the way that recovery goes. Now, we're getting better and better at preventing some of those backslides with more data. So, we use app-based recovery platforms. There are platforms out there, companies like Visible and Whoop and Aura that can allow you to track your biometrics and be a little bit more objective than just using how you're feeling to determine how hard you should push yourself. But in general, the answer comes down to finding sports and activities that allow you to work at a level that is your highest possible level without experiencing any symptom worsening, right back to that, first or second question about post-exertional symptom exacerbation. That's what we want to avoid. If we're causing a crash after the exertion, you've pushed too hard. But if we're getting you to a point where you're like, okay, this is challenging, but I'm not going to pay for it afterwards, that's the point we want you at. So that's how we sort of tend to titrate out return to play. When it comes to susceptibility, there is data to suggest that if you have sustained a concussion, it may be easier to concuss you in the future. Now, this is related to all of the literature that exists on CTE, which is called, chronic traumatic encephalopathy. I'm sorry. And what that tells us is often, not always, but often, when people sustain multiple head injuries, their brain energetics start to change, which does make them more susceptible to further brain injury from lesser stimuli. So always when someone is experiencing concussion and trying to recover from concussion, what we're also trying to do in parallel is make sure that we're curating their environment to limit their exposure to more brain injury, because yes, this person will now, the literature tells us that there is a probability that this person is now more susceptible to brain injury than they previously were. And of course, that means we want to protect their brain as much as we can.
And just a quick follow-up question that we're getting in the chat. Aside from concussion, is there any other type of brain injury that makes you more susceptible to future brain injury?
Well, I think when we talk about different types of brain injury, I think that in general, once the brain has sustained some trauma, so if we're talking about a stroke or an aneurysm bursting or a hemorrhage of some sort, once the brain has sustained an energetic challenge and it has sustained some trauma, you absolutely do want to limit exposure to more traumas and future traumas. So first and foremost, once someone has sustained and survived a brain injury, even if they've made a full recovery from that brain injury, what we want to do is protect all of the remaining neurons in that brain as much as humanly possible, so that we can experience, so that that person who has survived that brain injury can experience as long of a period of future brain health as possible, because every brain injury causes some loss of neurons, and we only have a finite amount of neurons. So we want to make sure that in the future we're protecting. In addition, I would be remiss if I didn't mention the fact that after a stroke, there are often, not always, but in most cases, there are environmental reasons why that stroke occurred. And physiological reasons why that stroke occurred. And that may have been uncontrolled blood pressure, high blood pressure. That may have been, uncontrolled high cholesterol. And in which case, what we want to do is we want to make sure that those lifestyle factors that may have precipitated the first injury are now under control so that a second injury does not occur. In fact, there's statistics from the American Heart Association, which tell us that if the only thing you do after your first stroke is get your blood pressure under control, that halves your chance of having a second stroke. So that's a really concrete and easy way that we can think about making sure that a second brain injury doesn't occur after the first brain injury, because some of your sort of lifestyle parameters may have placed you at higher risk of another stroke occurring. And similarly, when we think about aneurysms, unfortunately, someone who has had, the literature tells us and the statistics tell us that someone who has had one aneurysm is at higher risk of having another aneurysm. So what we often recommend for our people who are living with, who have survived one aneurysm burst or survived a procedure to clip or coil an aneurysm that they have, is to get yearly checkups, get MR angiograms that allow us to look at your brain vasculature and make sure that there's not another aneurysm forming somewhere. And if we can catch those things early, we can do a lot to protect the brain from another insult.
Thank you so much. And we're getting a lot of questions in the chat about concussion and post-concussion syndrome and recovery. And so, I just wanted to kind of highlight that SameYou's going to have a concussion campaign beginning quite soon to address more of these questions coming up. But it sounds like a lot of people are concerned about the limited treatment options after a concussion or for long-term concussive symptoms. Looking like towards our next question here, we had a question in the chat about what type of treatment options may be recommended for post-TBI spasticity that may be resistant to traditional pharmacological treatments, and if there are any research studies or any other prospects in that field, non-pharmacological options.
Non-pharmacological options. Yeah. So I would say, yes, there are non-pharmacological options for spasticity, especially spasticity related to brain injury. I would say two of the most promising areas in that regard to sort of research and look into is there is a non-invasive a non-invasive neurostimulation paradigm that is called transspinal cutaneous stimulation, TSCS. And it has recently been making waves in the spinal cord injury world, showing that this sort of TSCS paradigm can both improve voluntary movement and reduce spasticity in people with spinal cord injury. And most recently, there have been a few publications, and when I say most recently, I mean late 2025, early 2026, there have been some really encouraging papers being published showing that TSCS can also be used in brain injury and has a positive effect on spasticity. There are a couple of companies that are working in this space. One of the companies that comes to mind that I think is the furthest along in the United States, I mean, it could be different elsewhere, but they have FDA approval in spinal cord injury and they're working on FDA approval in brain injury, is a company called Onward, and they have a product called the ARC-EX, ARC-EX. And that's an example of a new technology on the market that really may have an impact on spasticity. The other technique that has really been that a non-pharmacological technique that has really been making waves is something that is called epidural spinal stimulation. Now, this is more invasive than the one I just spoke about, but for people with quite severe spasticity, the literature, the emerging literature has shown that it can be incredibly effective at releasing especially upper extremity spasticity. And this epidural spinal stimulation is just getting started in brain injury, where they implant a device that sort of sits on the top of your spinal cord and stimulates electronically to down-regulate some of the muscle activity that causes spasticity. But the results that have been published so far have been extremely encouraging for spasticity. it is entirely non-pharmacological. The implant can be removed, so it need not necessarily be a permanent implant, which is often, encouraging for folks who don't necessarily want something implanted for life. And also, just worth mentioning that both the TSCS and the epidural spinal stimulation can work synergistically with medication approaches. So, if some of the more traditional Botox, baclofen, etc. approaches are getting you close but not quite getting you where you need to be, these can be accessory and adjunctive care that doesn't interfere with the drugs or have any adverse events. So very new stuff, but really exciting and soon to be quite accessible, I would predict.
Yeah, that sounds like incredibly exciting research. Another question we had connected to that topic is your opinion about exercise in the treatment of spasticity, and if you think passive or active exercise can play a part in helping with recovery.
Oh, without a doubt. Without a doubt, I think that skilled care, skilled rehabilitation care, and helping folks to engage in home exercise programs can be beneficial to spasticity. The best way we can get rid of spasticity is retraining the muscles, retraining the muscles in the limb that is experiencing the spasticity to be able to overcome the spasticity and move the joint out of what we call synergy. So if you have experienced a stroke and your hand is kind of locked in this flexed position, the best thing that we can do is work the muscles that move these tendons, our extensors on the back of our forearm, and work some of our triceps and things like that will help us to move the arm out of synergy. And so absolutely exercise, careful exercise that doesn't push you into a threshold where your spasticity gets worse, or at least doesn't push you into a threshold where your spasticity worsens so badly that, it stays worsened for, hours after the bout of exercise. That would be an example of pushing things too far. But the extent to which you can wake up some of the muscles that work what we call antagonistically toward the muscles that are experiencing the increased tone, so that you can, when your hand starts to curl up, you can actually say, no, I'm going to activate those other muscles that work against the curling up and bring the hand out. That can be incredibly beneficial. And then in addition to that, someone mentioned in the question was passive care. One of the things that we work on a lot in our clinic is using things like soft robotics, where we sort of place a soft robot over the hand and it opens the hand out. So it actually, even if the person doesn't have the muscle strength to open the hand out, this robot can very gently open the hand up, stretch the hand out passively, just so that you don't get stuck in this position long term, and then the joints get stiff and get very hard to move. So even if you're not at a point where you can actively move those antagonistic muscles that will fight against the spasticity, just doing something passively that keeps the joints stretched and doesn't keep the tendons shortened and joints more stiff, you really can't do enough of that. Anything you can do there to keep that hand moving is going to be beneficial for you.
Thank you so much. And we're getting so many fantastic questions in our chat from all different parts of brain injury recovery, all different cities and countries, and just letting everybody know that we're going to have future AMA sessions, Ask Me Anything sessions. So if we don't get to all your questions today, I promise we'll get to questions at a later date. Our next question, we're shifting gears a little bit here and talking a bit about aphasia, and wondering if you can talk a little bit about the general timeline of recovery. So how long does it take for someone to recover from aphasia? And can you talk a bit about the chance of improvement years down the line from the injury or the stroke?
Yeah, absolutely. Language is one of our most complex processes. And so it can be one of the hardest processes to return after a brain injury. And it can also be one of the longest. Often after a very severe brain injury, we often see return of language both in similar in nature as well as similar in timeline to watching an infant or a young child gain language abilities. So you will see individuals who may have what we call an expressive aphasia, which is when an area of the brain called Broca's area gets damaged. And so the person can understand perfectly everything that is being said to them, but actually expressing responses back become difficult. And what we will often see when there's a severe expressive aphasia is the person goes from not being able to make any noises to maybe being able to make a few vowel sounds or a few consonant sounds to being able to make compound sounds like ma, 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 da, 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 na, na, na. And then you'll sort of experience, you'll sometimes see a bit more of a babbling period. So the person who's trying to sort of reactivate these speech motor pathways will try to communicate but not really be able to form the words, which can be, as you might imagine, extraordinarily frustrating for the person going through it, because once again, remember that this person understands everything, but when they're trying to speak, the words and the sounds aren't coming out, and they need to relearn new pathways for that. And so this process can take, some people are fortunate and it will return days, weeks after the brain injury. Some people with more extensive brain injury will need to, will have years of rehab ahead of them in order to experience recovery that yields functional improvement. Just like motor rehabilitation, so just like getting arm function back or getting leg function back, there's no window where you can no longer make recovery. But there is a window where you may need intensive rehab, if you're a few years out from your stroke and you really have plateaued in your progress and you've noticed that you haven't made any progress for a while. Something that we offer in our clinic, and I know that many places offer around the world, are these intensive sort of boot camp style speech therapy programs where people will get sometimes up to 6 hours a day of therapy over a 5 to 6 week period to really try to jumpstart this language processing. And that can include things like music therapy, because the reason for that is because humming and singing actually activate different pathways that still initiate speech, but they initiate speech through musicality, which is actually a different process from speaking the way that I'm speaking right now. And so if the area that is damaged that allows you to speak without music isn't going to allow you to initiate speech, then maybe you can bypass that by by singing and humming and integrating music therapy. There have also been some really incredible and promising trials that look at non-invasive brain stimulation such as transcranial direct current stimulation and transcranial alternating current stimulation these are two forms of brain stimulation where we basically, simply put, we put kind of like, one sponge on one part of your brain, another sponge on another part of your head, and a current will just run from, one electrode to the other electrode. There have now been multiple really high quality studies showing that if you do TDCS and TACS during speech therapy, it really augments the effect of speech therapy. And this has been proven in both acute stroke recovery, so people recovering from a brain injury that has recently happened, as well as chronic stroke recovery, so people who are many years out from their stroke who still have aphasia issues can try TDCS and TACS as part of their speech therapy, and it can be quite beneficial. The final area that's a little bit more science fiction-y, but is also, really emerging, is use of brain-computer interfaces for helping people with these speech issues to communicate. So there is a researcher by the name of Eddie Chang on the west coast of the United States who has been publishing some incredible work showing that implanting people with aphasia with a brain implant, his system can decode what they're thinking of saying and then allow them to say it through a digital device like a computer or a tablet or a phone. So there are some really encouraging and incredible augmentative and adaptive communication technologies that are being developed in parallel to some really promising rehab therapies.
I think one more spin-off question of this, and I know we're getting short on time here, but we had a really great question from someone who seems to be located very far away from some resources for aphasia recovery. And the question they asked is, what are some suggestions that you may have for aphasia recovery without a specialist's help?
Yeah, I mean, I would say there have been multiple systematic reviews at this point showing that app-based aphasia treatments, so aphasia treatments that are sort of training you through, retraining speech through an app that you can just download on your smartphone, have shown really and yielded really encouraging results. And so, in terms of if you don't have resources around, obviously we always want things to be done under the supervision of trained individuals who can guide things. When that's not possible, I think some of the best things that you can do is turn to the App Store and see what are the most researched and most well-validated speech therapy apps that allow for a patient to guide their own care or a caregiver to help someone to guide their own care. The other thing, that I think is really great is, which I mentioned earlier, is really diving into music therapy. Because that is something that you can do with your loved one on your own. The literature tells us that some of the best and most effective songs for getting people to start to sort of create first humming and then, starting to form words in their singing are songs that were emotionally salient to the person who had the brain injury when they were growing up and reaching adulthood. So for whatever reason, the songs that were really important to us and created the most emotional response to us when we were adolescents, those are going to be the songs that you're most likely to get the strongest response out of when you're trying to get someone to hum and sing. And so that is, again, something that can be done with very little resources, just a YouTube account or a Spotify account, and sitting with your loved one and humming them through and singing them through these songs.
That's so interesting that emotional connection can kind of help with recovery. That's super interesting. I know we're close on the end of our time, so we have two kind of last questions for you on here. I think one question that we keep seeing in the chat is, can you speak more about the connection between brain injury and mental health? A lot of our people in the chat are talking about feeling anxious or feeling depressed after a brain injury. Can you talk a little bit about the connection between physical and mental injury and support?
No, absolutely. You know, and just like everything I've spoken about, this is such an important topic. I think that people who experience a brain injury often feel these feelings of depression, anxiety, and sometimes other mental health diagnoses. And it's really crucial that we try to understand where these problems may be coming from. You know, I think that it's sometimes a given, you know, or considered a given that people with a brain injury will experience depression and anxiety. And so they often get told by their clinical provider, well, you had a brain injury, these things are to be expected. And there's no real follow-up or proper investigation of why are you feeling anxious? Why are you feeling depressed? So, you know, I think that it's really important that when someone is feeling these feelings after a brain injury, one of the first things that we want to do, of course, is make sure that a neuropsychologist who is experienced with brain injury is brought in to try and understand, okay, well, are you experiencing depression or anxiety because you've had a traumatic event occur and it has changed some elements of your life and you're having difficulty adjusting to this new, you know, change in situation for you? That can be one reason why someone is experiencing depression and anxiety after a brain injury. Another reason may be that they've lost social connection and their social health has suffered. Social health is quite different from mental health, and it focuses on your ability to form relationships, and it focuses on your ability to feel connected to other people, so that you're not feeling lonely, you're not feeling socially isolated. And if you don't have good social health, you know, so if after your brain injury you've returned, you know, to a situation where people don't necessarily, you know, your old friends aren't necessarily the same, you've had to move state or move location, and you have to build a new community, that can lead to feelings of depression and anxiety. So that could be another reason. We also have more concrete reasons, you know, so more concrete physiological reasons. So yeah, that can be directly connected to the brain injury. So, you know, one of the things that we see a lot in our patients after brain injury is they experience depression and anxiety as a result of something called mast cell activation syndrome. So in our body, we have these immune cells called mast cells, which are sort of like our first line defense for, you know, for pathogens, and they release all sorts of inflammatory chemicals that can flood the body with, you know, with inflammation. The majority of our mast cells actually live in our brainstem. And so if there's brainstem damage, these mast cells can become dysregulated for long periods of time. And what they do is they release all of these inflammatory chemicals. And believe it or not, when these inflammatory chemicals interact with the brain and interact with neurons, they can cause what we call neuroinflammation, inflammation of the brain or the nervous system. And that can lead to feelings of depression. It can lead to feelings of anxiety. It can lead to feelings of just general emotional upset. That can all, you know, that can all be related to some of these emotional feelings, but need to be addressed very, very differently to someone who is depressed as a result of having difficulty coping with their new living situation. So these are things that we need to also dig into. And then finally, you know, as I mentioned, a direct connection to the brain injury. So many people experience in a brain injury, experience damage to their frontal lobes. The frontal lobes, the front part of our brain, really control all of our emotional control, our ability to sort of regulate a stressful situation and make sure that we're, that we're able to, plan out what would be a coherent and well-regulated response to a tough situation. And after a brain injury, some of that can be lost and needs to be retrained in a very targeted way, so that people do, just like retraining speech, retraining walking, retraining arm movement, you also need to retrain, how do I remain cool and collected during a tough situation? How do I problem solve my way out of this situation without losing my temper or getting in a fight with someone or, doing something that I might regret? And these are things that require the access to a very, to skilled neuropsychologists who, as I mentioned earlier, have experience with brain injury. You really need someone who isn't going to just look at you through the lens of, oh, you're depressed, so I'm going to, give you antidepressants. That may be indicated in some cases, but in other cases, we just need to understand what is driving the depression, what is driving the anxiety, and make sure that you're getting the right care for the right thing at the right time.
I think our last question is kind of a really great connection to what you just asked. And for those of you who don't know SameYou, one of the big goals of our non-for-profit is kind of speaking about the connection between mental health and physical health and diversifying recovery. And one thing that you just mentioned is support. And one of the questions we had in the chat is just general tips on how to be a more helpful or supportive advocate or friend to someone who's going through a TBI. And can you talk a little bit about peer support as a topic for recovery, as our last question of the day?
Yeah, great question. I think that it's such an overlooked area of support for people going through any life-changing disability. And it's, I have witnessed over and over again the power of peer support, good peer support. And when we talk about peer support, it means that people who have lived experience with what a person is going through, coming in and providing information, providing support, providing friendship to that individual, so that they can help to navigate the next steps of their life. Something that I have seen over and over again on our own inpatient units, when someone has had a brain injury or a spinal cord injury and they show up on our unit for rehabilitation, is I can walk into that room and I can say to this person, I know that you've just had a devastating injury, but we're going to get you better. This is not the end. We're going to work and you're going to make a full recovery, and life isn't over. And I can say that until I'm black and blue in the face. And often the sort of reality is that a person will look at me and say, well, I don't believe you. You're not where I am. And yet a peer supporter, someone who has actually been through it, can walk into that room and say exactly the same thing, and they will be believed in a minute, because the person laying in that bed is like, you've been where I am. And so I trust that I'm going to be okay. And that I see that happen so many times in our clinic, in our hospital, and it's always a powerful moment. It's always an incredible moment, and it always leaves me wondering, why isn't this more of an integrated part of every single thing that we do in providing clinical care to folks with brain injury? Because it's such a real and unmet need. So I think to sort of narrow it down to practical advice, it really is just about being there. It really is just about providing friendship and providing closeness and providing support to someone who's going through something tough. And I really hope that, collectively as a clinical community and as a foundation, we're going to be putting a lot more work and effort into peer support and peer mentoring programs, as a major goal.
I think that's a fantastic way to end our session. We can't thank you enough for being here, and for everybody who's submitted questions. We know there are more questions to answer, and we'll be looking at all of them, and we'll be posting some more information on SameYou's website regarding this session. And Dr. Putrino, we're excited to host you again for future sessions, and thank you so much for your time, and thank you for everyone for joining us today. We can't wait to see you next time.
These were great questions. Thank you, everyone.